Welcome to Healthcare Heroes, a podcast powered by NPHub.com.
We created this podcast to highlight the incredible, hard-working heroes inside healthcare.
The entrepreneurs, advocates,
and providers that are saving lives and improving their communities
one day at a time.
These are their stories.
So Ashley, welcome to the podcast. We are officially live streaming on Facebook, and I am waiting for my marketing team that listens in to the first 35 seconds to make sure there's nothing wrong, no echoes. I'll have you do an introduction in a second. I think for all the nurses, all the nurses that are going to listen into this podcast who reside in Georgia, they're going to know who you are, which I think is awesome.
Wow, that's a lot. I don't know if they all know who I am, but I think that's awesome.
Well, they should. Okay, so this is like your coming out party. Okay, on the Healthcare Heroes podcast. But for everyone here who's going to listen in and who doesn't know Ashley, I would say Ashley is someone whenever I need advice on the state of nursing, I will call Ashley. She knows. I think she's just very plugged in. I personally think you're one of the most influential nurses I've ever met. I think people adore you and people respect the hell out of you, and it's incredible to see. So I certainly do. And that being said, Ashley, could you, just for a voice check, sound check, all the fancy stuff, do a quick intro and kind of who you are, what you're about, that maybe new title that you got recently. This might be worth mentioning, the humble brag, and we'll go from there.
Well, thank you, Krish. That was, I don't know how to top that introduction, so thank you. I really appreciate that. My name's Ashley Blackmon, and I'm a nurse practitioner currently working clinically in advanced heart failure at a tertiary facility in Atlanta. But I also spend my volunteer time with the United Advanced Practice Registered Nurses of Georgia, and I just started as of January 1st as their state level president. So I've been serving as the vice president and president-elect, and now I am taking on the role as president. Michelle Nelson is still hanging out with as immediate past president to help with everything that's going on, because there's a lot. And so I don't even know how to expand upon that, because through those two areas of my life, I wear a lot of hats. And I also run the Atlanta Nurse Practitioners Facebook page, which has over 3,000 members, and which represent almost 13,000 across the state of Georgia.
Oh, and, wow. That's a solid representation, 25% or so, yeah.
Yeah, it's awesome. It's very exciting. I feel like we get a lot of good networking out of it. And I also have 2 small children, so...
That's amazing. Can we start a rumor that you overthrew Michelle in this massive coup? I want to really spread a rumor. I think that's going to be the really good thing we get out of this podcast.
Well, I don't think there's any rumor. She really mentored me and fostered me to take this role. So I think a lot of good is going to come out of the next couple of years, UAPRN's growth and our influence in not just advanced practice nursing, but nursing in general in the state of Georgia and across the country. So
that's I think it's amazing. I think you and Michelle have always made a good combo and nice 1-2 counterpunch in a way. And I think it seems like Georgia's nursing leadership is quite strong from what I'm gathering, because we have a strong, we're connected in with Texas, Florida, some other, California a little bit. And I love seeing, just being in Georgia, seeing what you guys are doing and getting exposed to it. I think it's amazing.
Yes.
So, Ashley, you touched on something interesting, and I think we just dive into it, right? I think we're going to call this podcast The State of Nursing. So let's talk about the state of nursing in 2022. Right before we went live, we were sort of chit-chatting about what's going on in North Georgia, and let's just come in hot. What's happening?
Come in hot.
Come in hot.
I mean, I don't even know where to start, because you can look back on the past 2 years, and we went from this crisis state of wearing trash bags and reusing N95 masks for months that, are only meant to be one-time use,
Mm-hmm.
to, okay, now we're going to get fired for not getting vaccines, but now, like, in the current state where there's actually a federal movement to cap nursing pay. So there's a lot of different things going on, and it's really infuriating. It's infuriating to go, obviously, even from the beginning, to be called uh, heroes, even though nothing against the podcast name because I love it.
No
But
worry, we quit in 2019, okay, or 2018 when the podcast launched, so I have no shame around it, no issues. So,
but in 2020, when everybody's like, "Oh, you're heroes," I'm like, but I had this experience where we had to call in the National Guard at one point in 2020 because we didn't have staff, and people were, when we cut off visiting hours, people were rushing the ER and trying to get in, and there was just a lot of different things going on. And one of the guys that was standing by in his uniform, I said, "Oh, thank you for your service," and he said, "Oh, thank you for your service." And I just thought, no, no, I did not sign up for this. This is never in a million years. I mean, I worked in a trauma center where we, as a baby nurse, where we trained on mass trauma, mass outbreaks, emergencies, but those things would only last for 24 or 48 hours. Never in my life have I trained or signed up for something where I'm going to be stuck in a horrible situation for 3 years. That was not, I did not make that choice. So I was really kind of thrown off by that, and I've really been upset by this use of the term healthcare heroes, or you're a hero, but then we haven't been treated like that in any way. I'm a hero for wearing a trash bag and using an N95 mask to take care of your dying grandma. Like, I don't understand that. So yeah,
what's killing? Okay, so can you give like the 2-sentence summary of like what's happening with this North Georgia I don't even call it debauchery. Like, it actually doesn't make sense. But like, what's happening in North Georgia for those who don't know?
Oh, it's not. I apologize. I misled you. It's not North Georgia. It's I think it was Michigan, where
Okay.
they had 7 people want to leave one area of the hospital, and they went to the administration and asked for more pay. The administration said no, so they all moved to a different hospital or applied for jobs. And so the first hospital, instead of saying, "Oh, just kidding, we'll give you your pay," they filed litigation to sue them and say they could not leave to go to this other hospital. It would cause too much harm for the first hospital. Even though the second hospital said, "Yeah, we'll pay you what you want. Yeah, please come work for us." So there was actually, a judge had to get involved. Everything was put on pause, and you had days, a week, where neither hospital was able to use the staff just because they were trying to figure out if that was legal or not. And ultimately, the judge ruled that it would not hurt the first hospital, and that the staff were able to go to the second hospital. But the whole thing was insane, because it's like, you spent money on litigation instead of giving a raise to your employees.
Like, isn't the answer fairly simple? Like, this is a matter of supply and demand in some way, right? Like, let's just take the emotional side away from it for a second. This is supply and demand, right? There is a high demand for nurses right now. There is a limited supply. Yes. In that environment, the price goes up. Like, that's just how it works. Yes. So it's no different. I mean, it's a simple supply and demand model. I don't understand why. I guess in my experience, like, it doesn't seem, for like looking and speaking to nurses about like negotiating pay raises or just trying to have better leadership or better culture inside their either hospitals or clinics, it doesn't seem like they're asking for a crazy amount. It seems like it's the, you know, and obviously, like, you know, a supply and demand adjusted pay raise,
Right.
generally some additional PTO, maybe some extra CME, and like a nurse leader that doesn't like berate them. Like, these are like fundamentally 5 things. As in, I'm just not understanding why or what's happening.
There are a lot of moving parts, and unfortunately, I feel like what we're seeing, and we can even comment on the CDC's delayed response initially to the pandemic. There's a division between academia and clinical practice, and then there's also a division between administration and clinical practice. And a lot of administrators, especially in hospitals, are not healthcare workers and never have been. And, you know, they go and get their Lean Six Sigma and think that they understand a process and how to facilitate a process. But
It's absolute bull. It's absolute garbage, by the way. But because
I really appreciate that you laughed at that. But I'm just saying, like, you've completely removed the human factor of everything. We're not a machine. We're not a wheel in a machine. We're a human being trying to take care of other human beings. And if you don't make sure that we have enough pharmacists or enough pharmacy techs, or we have enough nursing techs or enough front office staff or secretaries or enough nurses, you're just going to stand there and tell me to work harder. It's not going to work. So we had this horrible situation happen the weekend of New Year's Eve, and it blew my mind because
and when you say bad situation, like this was like in your hospital, you knew of, or
in my
okay.
hospital, yeah. It's personal experience, but I know it's reflective of the experience of probably every other hospital across the country. So I have been working in healthcare since 2003. I've been a nurse since 2006, and every holiday is difficult to cover. Every weekend is difficult to cover. That's just something we know. So now we're in a global pandemic where we're relying on travel staff and agency staff to maintain our staffing for our hospital. Agency staff don't have contracts during the holidays. They always schedule their contracts to end right before either Thanksgiving or Christmas, and then not to start back up until after New Year's. This has happened since the beginning of agency nursing.
And why is that? Real quick. Do you know?
They don't want to work the holidays.
Oh, okay. Makes sense.
They're not contractually obligated to work the holidays, whereas full-time staff are. You know, you have to pick up, you have to be scheduled for so many holiday days and so many weekend days so that we have staff, right?
Mm-hmm.
So I had to work because it was my holiday and I'm contracted to do weekends. So I had to work that weekend holiday. And I came to work on New Year's Day, which was a Sunday, and I saw a nurse on a floor in one of the other buildings, like not even where I usually see them. I said, "Oh, well, what are you doing here?" And he said, well, I had to get floated here because we only had 3 nurses show up today, and the most experienced nurse has been out of school for 8 months.
What?
And this was a floor that is supposed to have 6, 7 nurses. So I was like, oh, and he's like, so I'm also charged and I have 5 patients. And I was like, whoa. I was like, okay, what can I do? Because I don't have access to the Pyxis. I can't get medications and help you dispense medications. But this is like stupid short staff. This is like somebody's going to die and nobody's going to notice until shift change kind of short staffed. So what can I do? And I was like trying to help a patient find their phone and, getting water for another patient. And because there was nobody and nothing anywhere. And there was this huge outcry about it. So we had this emergency meeting the following Friday, where the higher-ups said, we hear you, and you know what? The agency staff are all coming back. But that was the only answer. And I thought, well, what are we going to do next year? You know?
Would it? Doesn't it seem like I mean, like, doesn't it seem like the model for, like, okay, basically you have a lot of nurses are moving to travel nursing. One, because it's flexible, and also because the pay rates are like significantly higher. Doesn't it make sense to, instead of working with travel nurses, just like become like a beacon of like culture and like run a good hospital with your nurses and just pay them more instead of relying on travel nurses?
Well, a lot of hospitals are getting emergency crisis funding from the federal government. And that funding can only go to things like travel nursing. So they're standing there insisting that they cannot pay more than $35 an hour to their regular staff, but then the travel staff come in and are making $150 an hour. So there's no incentive because now there's no boundaries on traveling. You can quit and just go to the hospital down the street and do a travel assignment. So why would you be a staff nurse?
Yes.
But the hospitals are saying, well, that's not where the funding's coming from. This isn't something that we're going to have regular access to. So it's not in the budget to pay you more.
See, this sounds like this is like stuck in bureaucracy, right?
Yes.
Like that's like the. I'm sorry about my dog in the background.
Right.
You're good.
I'm surprised my dog hasn't started barking, so it's totally fine.
Isn't this a bureaucratic? Okay, the solution just seems so easy. I just don't understand why the solution is not. Like, anyone hearing this just says, okay, pay your nurses more. Oh, there's no budget. Okay, well, like, where's the budget being allocated?
So to make up for that,
Yeah.
they're billing patients more, right? So ultimately the average
really?
American, yes, absolutely. They're billing patients higher rates. They're billing Medicaid and Medicare higher. And so ultimately the patient is going to be the one that pays it and suffers.
So they're actually billing the patients more to cover this cost. Are hospitals run that? Are like the budgets and the margins that tight? I would assume these hospitals are like money making machines with kind of how much they charge patients already. Maybe a different question of like moving to the state of healthcare and not nursing, but like
yes,
that's kind of where
so
my head was.
Here's a good example, right? So we, are now going into the third year of a global pandemic, and with baby boomers being such a large generation, a large portion of nurses are actually baby boomers, so they're just retiring. They're done. Several of my good friends are like, I can't do this anymore, so they just have retired. Now the hospitals are begging them to stay, but they're like, I can't do it. So they're retiring. We have people going back to school, but they're doing education, not necessarily nurse practitioner. There are people going into informatics and research and legal chart reviews, so things they can do from home. And then there are people just leaving healthcare altogether. Now I don't know if you saw the story about this one nurse that now she's just a truck driver. She's like, the demand's there, the pay is there. I don't have to be on my feet all day. I can just be sitting in a truck. So it was like, okay, well, that makes sense.
I have not heard that, but that is crazy to hear.
I'm like, why be a nurse when I could be a truck driver? It's just, the pay's the same right now. So,
wow.
Yeah,
okay.
Yeah. But then you also have this factor of people getting ill and having disability, chronic disease, and healthcare workers dying. So when you compare the general population to the healthcare population, we've had a higher rate of COVID deaths than the general population. And even my hospital has been affected. We lost a physical therapist, one of our head physical therapists last year, to COVID. So, it's kind of hard. So then you get to this point where, all right, where's all the staff? So you want to run, let's say, an operating room. That's where all your income is, right? Is cardiac interventional surgery is the big money maker. And you should have all the patients you need because we're in the South, and obesity, diabetes, smoking, all of those things that increase heart disease are still really prevalent, right? So that hasn't changed. The number of patients who need interventions hasn't changed, right?
Right.
But the staff there to perform the interventions has. So now all of a sudden you have, cut down a quarter, a third, maybe even half of your normal staff. Your physicians are being told, well, you can't do so many elective surgeries because we have to go to the seniority, but maybe we don't have the OR time because we don't have the staff for the OR time. We're in a blood supply crisis right now where I've seen surgeries canceled because we didn't have enough blood products to do the surgery because we thought the patient would bleed too much. So it's so multifactorial, and it's affecting everything in this super vicious cycle. And we have patients waiting at outside hospitals for 5 days just to come get an OR time to be transferred into us to get their intervention. And so
It's
sometimes
non-COVID related, right?
that's not COVID related.
Yeah. Mm-hmm.
Not at all. And then sometimes they're sent to another hospital. Everybody's waiting for which hospital has the first bed, has the most staff. So,
Are these hospitals like in competition with each other? Like, is that like they are, right? Because that makes sense. So it just takes one hospital to really do well for a nurse, the nursing staff. Then theoretically you should have like a lot of nurses flock to that hospital, and then theoretically you would have other hospitals there then up their basically standards of how they're treating their nurses. So then like that's like how it should work. But instead of that, what you're saying is there's decisions to like litigate against nurses for leaving a private paying, like it's a private company,
right,
and to cap nursing pay, which doesn't.
Well, so the federal movement to cap pay is in response to the crisis in Minnesota, where it was in the news saying that they're going to pay nurses like, I think, $250 an hour, but actually they're going to pay the agency. So the hospital system in Minnesota that's in crisis appealed to the federal government. The federal government said, we'll give you these funds, but you can't hire Minnesota nurses because we can't have a war happen between the hospitals of their staff. So they went to an agency in Texas to say, we need you to supply us our nurses. And the agency is saying, we will, but we're going to charge you $250 an hour per nurse. Now, the agency may be taking 40% of that to cover their overhead because they can't use any Minnesota nurses. They're going to have to provide food and room and board and then the pay and all of the things for this agency, which is not unheard of. But now, because it's getting so much press, there is federal legislation requesting a cap on agency nursing pay, which is completely ignoring what the problem is to begin with. So, and now in Georgia, we are doing at least something right in that the budget review a couple of weeks ago is now going to send extra funds that we have accumulated in Georgia, since we are doing better than some other states as far as our economy. Excess funds are going to go to medical colleges and nursing colleges to fund nursing and physician scholarships. So that's a plus. That sounds like the right thing to do, to create more staff, healthcare staff.
But it's such a long tail solution, right? It's like, correct, hey, this will help in 8 years when that one doctor, or 5 years when that nurse graduates and can practice, after passing her exams. It just seems It's not immediately going to solve the problem.
It's not, but you're going to have to have multiple things in place, right? Because we've had nurses retire. So, of course, the limited staff you have, like you said, supply and demand, they're going to go where there's more pay. So, it does come back to how do we pay nurses more, and then how do we create an environment where they actually want to work. Nurses are not, and I know you understand this, but I feel like a lot of people in general don't understand. Nurses are not blue collar workers. They're not somebody who went and got a certification and just hand out pills and water. That they have to have a skill, they have to have critical thinking, they have to have pharmacology, they have to have anatomy and physiology, pathophysiology. They have to learn all of these things. They have to pass a test just to get into nursing school. Then they have to pass an exit exam just to be allowed to graduate nursing school. Then they have to pass their boards just to practice. But in 2020, we had all these emergency mandates across multiple states where they said you didn't have to take your boards as a nurse or a physician to practice. But nurse practitioners and physician assistants still had to take their boards. They were not allowed to practice. And I was like, we're the ones the most trained to do anything in a crisis situation.
That's interesting. So they let nurses and physicians skip the boards.
Yes.
But they didn't let NPs and PAs skip the boards. That
Correct.
sounds like the person crafting it was an MD who just who's afraid of all those damn NPs stealing our jobs.
Yeah, basically. Stupid nurse practitioners.
Oh, yeah, they're taking our jobs.
Just taking our jobs. I'm like, what jobs? What jobs have I taken? Again, a supply and demand. If the patients are there, right? Like I moved from one inner city county to another inner city county a few years ago. And when I was like, well, I just want to see somebody closer to home, I started calling practices, and I had to go through 6 practices before I could find somebody who was taking new patients. Like, why? I'm in Atlanta. What do you mean you're not taking new patients? Well, who am I going to call? I don't know. I don't know who you're going to call. What? What kind of access to care is this? If there aren't enough providers and I'm in the city, I'm not in Brunswick or Watkinsville. I'm in Atlanta.
Yeah. With yes, no, I'm with you 100%. Actually, I had the same issue myself in Atlanta. You can't get an appointment anywhere for anything for like months.
No.
Months. So okay, navigating back to the idea of the state of nursing, right? I think we're talking a lot about the negatives, which there seems to be a ton of. How does this play out? Like, why would anyone want to continue becoming a nurse? Well,
okay, so people are joking that we're hitting rock bottom, and I was like, I don't know. I think we're kind of in a free fall. I don't feel like we've hit any bottom. Everything's still on fire, and it's probably going to continue to be on fire. But I truly 100% believe in my soul, because every year I fall more in love with my profession, which I know seems crazy, but I do. And
the masochistic side of you, or
maybe.
Okay, just trying to understand.
But I have never been more proud to be a nurse than I am right now. And I think that our profession, we are the ones that make the logistics happen. We are the ones who kind of figure out how to get from point A to point B. And healthcare is not going to get better without nurses stepping up to the plate and leading the charge. It's not going to be physicians. I know physicians want it to be them, but they are not the logistical people. They are the diagnosticians or the surgeons, and they are brilliant, amazing, wonderful, skilled at their job, but they are not the ones that are going to lead the change. It's going to have to be nurses. And so without us stepping up to the plate and creating the change, it's not going to happen. But I know we're going to do it. I know it's going to happen. That's just all there is to it.
What does successful change look like in the next 2 to 3 years? Right, so COVID started in 2020. We are 2 years in to this pandemic, right? March 2020, roughly.
Mm-hmm.
What does the next 2 years look like for what needs to happen in the next 2 years for this to be more successful?
So I think that we're going to have to utilize a lot of creative thinking in as far as our staffing, but not to the staff's detriment, right? So if you can utilize somebody's skills, like there is the uh, um, telemetry electronic model where you have an ICU experienced nurse who will watch the telemetry and the monitors and cameras in halls and stuff to make sure patients are okay and nobody needs something immediately. So right now we just have either a secretary or a telemetry tech that will watch telemetry, and then the alarms will cause alarm fatigue and all of this stuff. But you could have an ICU trained nurse that could access all of that from home and help facilitate which patient needs immediate attention when, and that would remove that burden from the staff that is there, right? So that's one
Almost
option.
kind of like a floor general in a way, like.
Yes.
Okay, got it.
I think another option is we have to go back to a teams approach, and we need to start utilizing nurse practitioners in those teams. So ICUs now across the country all use advanced practice providers. There aren't enough intensivist trained physicians to be available all the time. So they have physician assistants, nurse practitioners, staff in the ICU, right? So you have your nurses, your techs, and you have your advanced practice providers. I think that if you took it to the next level and you did that kind of staffing on the floors, it would cut down on medical errors dramatically. I remember, and it's not a unique thing. It's just an underutilized thing. Because I remember as a baby nurse, I worked in a hospital that was teaching and had a lot of residents. So you rely on all the grunt work to be done by the residents. But there was one surgeon who had a nurse practitioner, and she would just always be there. You knew she was there every day, Monday through Friday. If you couldn't get the resident on the phone, or the surgeon was in the OR, you could just call her, and she was just always rounding, always helping with things, always teaching. It was a vital resource, and I think that kind of resource is not being recognized or utilized appropriately, and that we should have other facility, nursing homes do it, skilled nursing facilities do it, ICUs do it. We should have every level of care utilize an advanced practice provider as a go-between, or also, like you said, a floor general. So you have a floor general on that's electronic, and then you'd have a floor general that's in person, and I think that would radicalize the healthcare that we offer now.
That's interesting. So right now, that's not really being done, right? Because mostly NPs, they're typically working at outpatient facilities. So are you basically saying NP should all? Yeah. Well, I guess we'll walk me through what that looks like a little bit more.
So it's interesting because Georgia is unique in that we have some of the most restricted practice in the country when it comes to nurse practitioners, and so we have to rely on physicians and hospitals to create, or just facilities in general, to create our jobs. We can't go out and create our own job. We have to rely on them to create our jobs. Or we can, but we could not prescribe medications. So there's that caveat. So what we're seeing happen right now is specialty practices are the ones that are growing the most, and they will hire a nurse practitioner to see patients in both the clinic and the hospital. So they want the nurse practitioner to just be available to kind of do all the things, to kind of pick up anything the physician can't get to, because, the physician's time is in such high demand. And so with that kind of evolution of, instead of just running a family practice clinic in rural Georgia, which is very, very needed, or working in an ICU as a full-time person available, which is also really needed, there's this huge growth where that's where nurse practitioners are being utilized the most, especially in the state of Georgia, is they're being hired by specialty practices to specialize and see patients in both the clinic and the hospital. But as amazing as that is, and since that's what I do and I really enjoy it, I still think there's growth in other ways. I think there's growth in the hospital that we could be using more nurse practitioners.
That's interesting. So I guess talking a little about staffing levels and just going back to maybe supply and demand a little bit, right? So we know that there's a shortage of RNs. And then you basically have a ton of nurses that are going to school, they're graduating as an NP, and then everyone is now talking about oversaturation. It's not really oversaturation with NPs, it's oversaturation of like fresh graduates, right? The graduates from like year 0 to year 2, year 3 that are like kind of, not my words, but have been described as like deer in the headlights sort of thing, right? Like, really trying to figure out how it works. And then year 3 onward, NPs can get any job they kind of want. That's like what it seems like in the market from an outsider looking in.
Yeah.
How do you get these fresh graduates? These, they went to a program, during COVID, struggled like hell to find a clinical rotation. We already know it's hard, but then during COVID, it's got even worse. They graduate, but then no one's employing them. And they get paid more to go back as a nurse.
Yes.
What do you do?
Hold on. I got to plug in my computer. I didn't realize it wasn't, that it was dying.
Oh, I thought you were going to be like, oh my God, hold on. I'm going to give you the perfect answer right now. This is it.
I do have the perfect answer, but I have to plug in my computer.
That's fantastic. I think we're going to, I'm really excited for this perfect answer. I'm going to title this section, The Perfect Answer. Solve it.
Solve it. Okay, so this is also multifactorial, right? So how physicians enter the workforce is through residency programs.
Yeah.
But residency programs have come under fire often for decades because they pay them like $40,000 a year and work them 80 hours a week.
Yeah, was it 6 on, 1 off?
Yes, 6 and insane numbers of call. Maybe you did 36 hours in a row, which everybody says that's not safe for patients. However, because old school docs will say, well, I did it, so you have to do it, right?
Oh yeah,
this is how you learn. You see as many cases as possible so that you will always be able to recognize it when you see it again. That's how physicians work. And they say, well, research shows that long-term health outcomes are not affected by this lack of sleep and utilizing residents, which I think if we are to do studies now that we're in the going into 3rd year of COVID, I think we would see that change, because what has kept residents in line from killing patients is experienced nurses. And we don't have that right now. So that's how physicians enter the workforce. Nurses, so they're undergraduate, they graduate with a bachelor's or an associate's, and they enter the workforce. Most of the time, especially if they're in like an OR or an ICU or labor and delivery, they have to enter into a nurse residency program. And the nurse residency program is a really intense orientation where they're paired with another nurse. They have to do all this work in a notebook, have all these skills check offs, and it can be anywhere from, a month to 6 months. Now, since I was a new grad hired into an ICU, a trauma ICU as a baby nurse, my residency / orientation was 6 months long. So
You're just for clarification, the residency that MDs have to do, that feels like it's a national program, right? That's like the process. If you want to become a doctor, you want to become an attending or a licensed physician, you have to pass the steps. You need to do a residency, 3 years or whatever. That's what you have to do. But for nurses, it feels like this quote unquote residency that you're talking about. What's the other word? Orientation. That's it's hospital by hospital.
correct.
So it's not. There's no national regulation to this.
Correct.
Okay.
So then we'll fast forward and look at physician assistants, nurse practitioners. There's nothing in place for that. Absolutely nothing. You are expected to figure it out on your own or find one of those rare residency programs where someone will hire you. The VA is an example of a place that has a residency. Some of the ICUs, a lot of the ICUs in Atlanta have residency programs, but they're very, very, very difficult to get into. And you're committed for a year of working at like half pay. And it's not 80 hours like physicians, but it's still like you have to read so much, you have to do so much, you have to show that you're doing so much. But that is again hospital by hospital and there's no standard. So if you are a nurse practitioner who is aware of your limitations, you might request in your job interview, can I do halftime? Can I do this? Can there be some kind of some support, some kind of onboarding? But without knowing that and negotiating that and then having somebody hire you willing to do that, it doesn't happen. So I think there are two different ways we need to approach this. One is Wellstar currently is doing a bridge to practice program for NPs that they hire. So they need nurses more than they need NPs. So they ask that you commit to a year of doing something like 2 days as a bedside nurse and 1 day as a nurse practitioner. And they rotate you through the different practices that they might have an availability. And at the end of it, you can say, I'm really interested in such and such area. Okay, great. Well, we've already trained you. So let's kind of transition you to this specialty area. And that's going to be where you're going to end up either being part-time or full-time. So they're trying really hard to ease nurses that are now new grad nurse practitioners into it while meeting needs that they have in other places, which is brilliant. And I think that this program's really new, and I think that what we see come out of it is going to be something that other hospitals are probably going to want to utilize.
I do think that's really smart, actually, and I can explain it why after. That's really smart.
Yes. Mm-hmm. The other thing that I think we should be doing is instead of necessarily having haphazard clinicals, I think family nurse practitioners particularly should have a school clinic that they run. And then that be something that they do full-time or close to full-time hours with somebody there to observe. But you could meet so many more needs. You could meet the patient care need, but you could also meet the experience need for nurse practitioners to have this kind of dual where they're doing clinicals, but then maybe they transition into working situation where they run the clinic and then they're gonna get the experience they need, but then graduate into job experience, things like that. I think that if more practices facilitated a program like that, that we would that it would not be such a shock, and it wouldn't be so hard to find jobs.
Interesting. So it's kind of like, the first answer you're basically saying is sort of like let the schools do what the schools do and then create some sort of bedside to NP transitional residency program, right?
Mm-hmm.
So that's option one. Option two is then you have the universities take on a larger onus to try to make the clinical experience better so they come out basically knowing more. Is the general idea that a fresh graduate NP just doesn't know it, like they don't have enough experience, they're not as good with patients?
I think well, that's a loaded question.
I can see why that is loaded. Yeah, I can see that. I'm not going to retract it because I do want you to answer it, but like, I do see why it's loaded.
So there are multiple perspectives when it comes to the new graduate NP. And, as someone who has worked with residents, with resident physicians, their very first day out of med school, very first day as a resident, I think that it's really unfair the amount of attention that new grad NPs have gotten because new physicians have not really been any better. So you have to take into account personality and work ethic as part of their personality. And what school did they go to? Because every school is kind of different in the amount of clinical hours they require.
Mm-hmm.
There's this transition towards we should all be doctorate prepared for entry to practice. However, the doctorate prepared programs, unless you're going to do specialty like CRNA, like a nurse anesthesiologist or an emergency nurse practitioner, I'm kind of confused on why a family nurse practitioner would need to be doctorately prepared when yes, there are more clinical hours, but then there's also this whole extra research didactic portion, and
it's not about like practicing. It's about like it's about like the doctorate and the education, and
right,
and that's not
right.
relevant necessarily. Okay,
not necessarily. I mean, I am not doctorately prepared, so I can't. I'm speaking from the outside looking in. So there's push from faculty to say, well, we would solve this by doctorately preparing nurse practitioners. And having them, and then there's a push from accreditation centers. Well, we just need to increase the clinical hours. So the newest recommendation, I think came out the first week of January, is that they're going to require all schools now to, instead of have 500 clinical hours, they need to have 750 clinical hours minimum. Now, I graduated from a program that had 750 hours minimum. But a lot of programs, especially online programs, do not have 750 clinical hours available to their students. So you're making a demand without already meeting the need. Like the problem isn't the underprepared nurse practitioner; it's the underprepared program that doesn't have clinical placement, which because that's what you do, is place nurse practitioners with preceptors.
That is true. And I like to think that we're God's gift to nursing, but the truth is all we do is try to treat our preceptors well. And like try to appreciate what they're doing.
Right.
And we do this thing where it's like if someone's going to give time, we're going to compensate them because it's the right thing to do. It's really really revolutionary, the concept, which is it is ridiculous. The scope of that. Just as a side note, how do you feel about a lot of NP programs now transitioning to either hybrid or just being fully online? Even top tier programs,
right?
Like elite programs.
So this is fantastic. This is one of the ways that nursing is revolutionizing healthcare, because not only do we have a shortage of nurses and nurse practitioners or providers, but we have a shortage of educators. So if you transition to online, what you're doing yourself a disservice in is clinical placement. That's where you lose your edge, is you're losing the ability to place people in clinicals well. But you're utilizing a resource that's not very available, and that's educators. So if I could get online and do EKG interpretation for 7 schools and 800 students, which I haven't done, but I wouldn't mind. That would be amazing, right?
Yeah, it would be. You're right. Look, if you have one, like at some point, right, the best math professor, the math teacher for like a 4th grader, should be teaching as many students as possible, right? Like the best nurse educator for, I don't know, like anatomy, let's just say, should be teaching as many as they can, right?
Yeah.
That absolutely makes a lot of sense.
Yeah.
Do you think? Okay, so I guess I don't want to ask a leading question. I want to ask what I'm hearing is how does nursing deal with the backlash of there's a word, the taboo of like online education being less stringent or less valuable than in-person education?
Well, pre-pandemic, I would say very obviously it's because we don't do clinicals online. Like anybody, anywhere can do their didactics online. Obviously, different learning styles works differently for other people. And I remember talking to a resident once where I said, I worked full-time as a tech when I went to nursing school. So I was both working and doing clinicals. And then I worked full-time as a nurse while doing nurse practitioner school. So I did clinicals and was working. And he was like, oh, that sounds terrible. I'm so glad I didn't do that. I just was school full-time and then residency full-time, which allowed me to do all of my learning and focus only on my learning. And I was like, great. Well, but all the hands-on stuff I always learned. You are seeing as many cases as possible, whereas you have never sat at the same patient's bedside for 12 whole hours in a row. And to do that, people call it the nurse's sixth sense. I know when something's going wrong. I might not be able to explain it to you, but I have training that you don't have, and experience that you don't have because of our different approaches to things. So when people say this is to your detriment because you're just doing stuff online, you're not building these relationships, I'm still doing all my clinicals in person. Now, I say pre-pandemic because post-pandemic I have seen some situations where people have done stuff online, such as telehealth visits, and I do not think that is appropriate. And but I've also seen that done with medical students and medical residents, so they can't point fingers at just nurse practitioners. It's all of healthcare, and it's going to be detriment of the patient because you're going to have a whole bunch of providers not know how to actually take care of you in person.
Right. And I think some nursing schools went to like a simulations for their undergrad nurses, right, instead of like clinicals in a hospital, something like that.
Well, because we shut down because of COVID, so we weren't accepting any students. We wouldn't let any students in. No clinicals, no nurses, nurse residents, and then we had the crisis after that first wave calmed down in New York. We had a crisis here in Georgia where Albany, which is southwest of Atlanta, was overrun, and they were telling everybody, nursing students, nurse practitioner students, you want clinical hours, just go work down at Albany. And some people did, but it was there are horror stories that came out of that.
Wow. It sounds so. If we would backtrack a few minutes, we go to this residency idea, right? The reason I want to go to the residency idea is because I think it's going to be easier. Or maybe you tell me. I think the second idea you had said, which is like, hey, schools should create better standard and have a clinic, like a hospital run clinic that FNPs could like run, that requires the schools getting into then running and owning a clinic, which is, I think for a lot of programs, just they're not aptly equipped to like run that and to do one of those.
But they already do. They already have them. They already have clinics for the students, right? So Georgia State, for example, has a student clinic, not for them to do clinicals, but for you to go. Like okay, I'm attending Georgia State and I have a cold, but I don't have insurance. I'm going to go to the Georgia State student clinic,
Oh, that's what you mean. Okay.
right?
Yeah, yeah.
So
Okay, okay,
I'm now
okay.
a patient and I can be seen there. Why is it not being run by the nursing program and the nurse practitioner program?
Yeah, because every school offers that, right? Every school, yeah, that actually is a really good idea. Wow, doesn't seem like ridiculous at all. I mean, you wouldn't be able to do like every student couldn't run through that, but at least a handful could.
Right.
You know, why not create like what's stopping? How does one go about creating a standardization around residencies? Like, why not just and see? I think a lot of nurses are open to this because they see the value out of doing a residency, even if they get paid a little less for a few years, to then jump up in there. Especially if that residency program, if it was even possible for a residency program to sort of guarantee them an employment at another location for X amount of dollars, right? And maybe easy math could say, hey, do a 1-year residency program where you do split that because there is an equal supply and demand. You're an RN for 2 days, you're an NP for 2 days. You make, I don't know, 85, 90K a year doing that for 1 year. And at the end of that, we will place you into a full-time position at, I don't know, like 110. Maybe. Like, those numbers seem good. You look online, like, that seems reasonable. Why not that?
So, one argument that I've heard from nursing faculty is that the funding isn't there, right? So you hear of physicians graduating with, $1 million in student loan debt, and hopefully nurse practitioners don't. I still hear some pretty hefty debt accrued, depending on how much they worked or not as a nurse during school. But the offset is you're going to get paid less during a residency, so that should account for some of it. And then the other thing is the university, Augusta State University, their medical school program is their medical school, and Mercer University's medical school are now doing these programs where your residency time is cut if you agree, for physicians, if you agree to practice in a rural clinic for 2 years, 3 years. I don't know how long it is. Maybe even just 1 year. Why can't schools partner with the state, right, and get state funding for residency programs for nurse practitioners in the same way? Hey, you're gonna when you graduate, if you qualify for this program or whatever, you're gonna go to Jackson, Georgia, and work for a year, but that's going to be part of your residency. You're going to get all this really amazing experience because you're not going to have access to anything, and then that would offset the cost. So there are all these resources, and we're just not utilizing them because the argument is schools would then have to increase their tuition rate, and I don't think they would need to. I think they're just not doing it.
For what it's worth, I've spoken to thousands of students, and everyone would pay more in tuition to have rotations at clinical set up for them. Every single one.
Yeah, it's so stressful.
It wouldn't even be a question if
Right.
these students would pay an extra $2,000 a semester, $3,000. Pick a number, they'll pay it.
So they're turning around and paying you, right?
Basically.
Instead of their school, right? So the money's going to you and not their school.
They'd rather go to school. It'd be cleaner. It'd be easier.
Yeah.
What's crazy is in that residency example, like, why it seems like from my experience looking at universities, working with a few universities, it seems like their primary goal is just increasing the number of students they're attracting. Like, it doesn't seem like that is I think they're very much focused on getting the nurses graduated, or at least enrolled. I don't see post-graduation, first position, that process being really discussed a lot.
Right.
Maybe you know better. Maybe you can correct me if I'm off base here. Is
Well,
that something that,
I know
yeah.
that's something looked at closely for undergrad, but I do not know if that is something looked at for graduate schools. You have to have a certain pass your boards rate to stay accredited, but you don't have to have an employment rate.
I've never heard of one. Yeah. Do med schools have that with residencies, like percent matching or?
Well, they have a match day, and it's
Yeah.
very complicated, and so they do have matching.
But are
I
universities
don't.
measured on their match percentage?
Well, I mean, they have to send people somewhere. I don't know. I actually honestly don't know if they're measured on match percentage. That would be interesting.
No? It would be interesting to see, because I think right now there's no one is evaluating these programs on if their students are getting positions. Like,
Well, and then, okay, I could go in 2 seconds and get a job in, or even create a job in a full practice state, but it's going to take me forever to find a job here.
yeah,
And
that's what I think. I think your answer, or not your answer, Wellstar is doing, could be scaled out, right? Because I know RNs, or rather fresh grad NPs, want to get a job, right? That's like their big goal. They want to leave the bedside, they go back to school, they spend all this time going back, they're working while they're in school, they're doing clinicals while they're in school, they have these 3 jobs, and they want to pass their exam, and they want to start practicing. I think creating a model where they're working as an RN for a few days a week and working as an NP for a few days a week, would that be enough for a fresh graduate? Like, do fresh graduates hate the idea of being an RN again?
I think, again, that would just depend on the person,
Yeah.
because there's still, you can still utilize your time as a bedside nurse to be learning, right? Well, what did this person say? Why is this way? Let me look this up. Let me take notes, and then tonight I'm going to look it up. um, so you can still be learning how to apply, from a diagnostic stance and not just a bedside stance, and then know I'm meeting a need by doing bedside, so that I can also, like, yeah, does it suck that you committed all this time and now you're still having to commit time? Yeah, but that's what residency would be anyway. And this is not a residency, but it's a bridge. It's like a bridge/residency.
Mm-hmm.
So take it, do it.
I mean, better that than not having a position, right?
Right.
Or, yeah, I think that's really interesting. Actually, as we're coming up on like the hour, almost hour and 10, hour 20 mark, I want to restrict over time. Could we hit one more topic and talk a little bit about the UAPRN? Not necessarily even like what you guys are doing, but I think like why especially kind of what's happening with nursing in 2022, how your state organizations can actually be of value. Like, obviously, like outside of the networking, right? I think everyone knows, okay, networking can be there. But, like, what are the specifics that a state organization can provide that people don't know about or don't understand yet?
Yes, perfect. Thank you for asking me that, because I feel like I've just been on this soapbox this whole time. So
It's a good soapbox.
So UAPRN, everybody's heard of AANP, which is at the national level, and then they have representatives at different state levels and regions. But there is no state organization focused just on APRNs, especially nurse practitioners, as there is for UAPRN in Georgia. And so your dues, yes, they go to great things like continued education and a subscription to the Nurse Practitioner Journal, but they also go towards our lobbying efforts for full practice authority. We are focused on very small things, since this is Georgia and we have a lot of political advocacy to do, but the ultimate goal is full practice authority for advanced practice nurses in Georgia, because that would answer a healthcare need for all of Georgians. Being a member of our organization would contribute to that greatly.
I think with the amount of every other month you hear a new state adopting full practice authority. I think New Jersey, there was just, it's over a month. There was New Jersey or Maryland just did it a few months ago or very recently. Do you think Georgia's coming up in the near future?
I hope so. Well, so here's the thing. COVID really pushed a lot of states to write legislation, not necessarily has it passed in all those states. And then some states, like I think it was Utah passed, maybe Mississippi. Oh, dang it. I think it was Utah. So they passed its full practice authority after 1,000 hours of experience or your first year. And so 6 months to a year, depending on how much you're working. And that's not considered by AANP full practice authority because there's still a stipulation on it. But even something like that in Georgia would be amazing. It would be wonderful. And we've had every year there's been something with full practice authority, some legislation with full practice authority on it in Georgia since 2018. But they all die in committee or they don't get called. And so being active now and helping contribute to lobbying efforts now is going to get that passed.
That makes a lot of sense, right? Because the one benefit of what's happening with the state of nursing is that it's on a lot more people's mind now.
Yes.
Right? I don't think people weren't even aware of what was happening. And now you're hearing it in the news. Now you're hearing it online. You're seeing it on you're seeing on social media from non-nurses.
Mm-hmm. Well, and we want full practice authority for everybody. We want full practice authority for EMTs, for physician assistants, for paramedics, for respiratory therapists. We want full practice authority for everybody. We don't want physicians to be the only ones that can practice to the full extent of their license. We want dental hygienists to have full practice authority. There was a petition a few years ago to just go into the rural areas and clean teeth, and they were denied because the current state law says they have to practice with a dentist. Why does any of that make any sense? Why do you have people who practice, who study and pass tests and exams that they're required to pass at a national level, but your state says you can't do that. You still have to practice this way.
You can't open up your own business and just be a dental hygienist. Right. Build your own staff. Yeah, you're absolutely right about that. You don't need to necessarily I don't want to get in trouble for saying this, but I'll say it anyway. But you don't necessarily need to see in this case like a dentist or a physician for something really minor or for a routine checkup. In fact, honestly, in the healthcare model, it doesn't make a ton of sense. Right.
Why can't I get my teeth cleaned twice a year and then maybe once every couple of years see the dentist, or depending on my dental health? Right. Why am I having to see a dentist every 6 months? So why can't I see a nurse practitioner every year or every 3 months, depending on what your situation is, and then check in with the specialist when needed?
Especially when it takes 6 months to, one, get a new appointment with someone, and two, seeing a specialist is going to charge you $500 even if you have insurance.
Yep.
That's another pain in the butt. What?
Oh my gosh, we could get off on that.
I do want to vent about it, but it doesn't make for good podcasting.
Another time.
No. Okay, so lastly, I think to wrap up, maybe talk about how people can find you if they want to get in touch with you or with your team, how they can do it. And then lastly, any events that UAPRN is doing this year that we should attend.
Yes. So we're going to have our healthcare summit, which is usually our annual conference, but we're kind of combining Transitions Day with the Atlanta chapter, and with it now Transitions Day is something we do every May through the Atlanta chapter, where we offer free programming for new grad nurse practitioners. So if you need help with your resume, interviewing skills, just good networking and access to different things, that's what Transitions Day is about. So we're going to have that at our healthcare summit. But we're also going to have a lot about political advocacy, continued education credits, and other things like that. It's going to be at Stone Mountain on May 13th and 14th. So you can go to uaprn.org or UAPRN of Georgia, so uaprnofga.org. You
We'll put a link. We'll put a link in the notes, guys. We got you. We got you.
And then you can look me up, Ashley Blackmon. I'm on Facebook, LinkedIn, Instagram. My professional page on Instagram is True Heart NP. So it's true_heart_NP. And I post a lot of cardiology education and nurse advocacy content. So yeah, reach out. Let's talk.
I love that. That's amazing. That's amazing. Thank you so much for being on the show today.
Thank you for having me. And you made a couple of comments where you're like, oh, I'm going to get in trouble. And I've been thinking, probably going to get in trouble for some of the things I've said too. But you know what? It's important. We have to, if we don't have the conversation, then what are we doing? So
exactly.
Thank you for utilizing this platform to bring focus to this. I really appreciate it.
Anytime. No, absolutely. Honestly, this was a lot of fun.
Yes, it's always fun to talk with you.